Totally powerful.
No, not yet. Dear audience, colleagues and friends, this is a great honor to be here and to present. I'm going to launch the early chronic pancreatitis section 1 with the Hungarian Pancreatic Study Group perspective. And I think I need to start with one of the most one of the earliest and the biggest milestone of the Hungarian Pancreatic Study Group results, namely the first registry analysis. In this analysis, 300 adult acute pancreatitis patients were analyzed, and these were prospectively collected from 17 Hungarian centers in a 2-year period. And among all the huge results and conclusions, I would like to highlight one which showed that more than 20% of these cases, the acute pancreatitis was recurrent. This is not the only study which revealed this result. Another study showed also that 1/4 of the analyzed patients were recurrent attack. And basically, the second attack was mostly alcoholic and biliary, and the third attack mostly alcoholic. We need to mention that the recurrence is very, very important, because in some cases it can lead to chronic pancreatitis and pancreatic cancer. This study also concluded that if the biliary or the cholelithiasis is resolved immediately after the first attack, that may reduce the recurrent frequency. As David Whitcomb was showing previously, the conceptual model of the chronic pancreatitis progression, I also would like to highlight that not all the patients who are at risk for acute pancreatitis resolve acute pancreatitis. There need to be an extra injury which triggers the acute pancreatitis. And basically 3 things can happen. The acute pancreatitis might be resolved without any functional or morphological injuries, or the organ can be sensitized to more attacks, and then recurrent acute pancreatitis occur. And also, when there is a dysfunction of the organ, early chronic pancreatitis, and when there is a morphological disturbance, chronic pancreatitis might occur as well. And basically, at the end stage, chronic pancreatitis is when more than 90% of the organ has dysfunction. A few years later, when the AP registry became multinational, namely 13 countries joined, we had enough data, more than 1,300 patients. So we could have more groups like AP, recurrent acute pancreatitis, and chronic pancreatitis. And we also could make subgroup of how many episodes occurred in the AP registry. What we analyzed here, that patient who had acute pancreatitis, what was the frequency of chronic pancreatitis morphological changes. And as you see, when there was only AP of the patient, it was 0% of the chronic pancreatitis occurrence. And when there was the second, third, and fourth episodes, the occurrence of chronic pancreatitis, the morphological changes elevated. So basically, after the fourth episode, there might be the risk for the chronic pancreatitis. So at this time, we also had the chronic pancreatitis registry, and from the other side, we also analyzed in the chronic pancreatitis registry how many patients had acute pancreatitis before the CP was diagnosed, and basically 98% of the patients had at least one episode, and the average was 4 episodes. So these two sides of the comparison show the same results. The early chronic pancreatitis cannot be diagnosed by any single biomarkers because there is no, because the biomarkers are non-specific. But because we had this AP, the different amount of attacks and the chronic pancreatitis, we could have the analysis of different levels. And we analyzed 102 biomarkers, and basically 15 showed significant differences in these main groups. And when there was significant differences in the biomarkers, but no morphological alterations, that is basically the second and the third attacks. And this might reveal as the early chronic pancreatitis. When there is morphological alteration, then we talk about the chronic pancreatitis. In the same publication, this was a real translational publication. We also had an animal model of the hexagon-induced acute pancreatitis. So basically, mice were intraperitoneally injected with cerulane, and we induced acute pancreatitis with cerulane 1 time, 2 times, 3, 1 time, 2 times, 3 times, 4 times, and 5 times in 2 weeks period. And when we analyzed we analyzed the histology, the pathophysiology showed that after 3 or more attacks, when there is no morphological change, but there is a different necrosis level, different edema, leukocyte infiltration, that might be called as the early chronic pancreatitis. One level above of the exogen induced acute pancreatitis is the knock-in transgenic animal. Miklós Rahimtóth was the first who produced a preclinical mouse model where the trypsinogen autoactivation was increased by a 50-fold elevation. And he found that spontaneous acute pancreatitis occurred with edema, necrosis, and serum amylase elevation. And during the time, with the age of the mice, the progressive atrophic chronic pancreatitis occurred with cell loss, fibrosis, dilated duct, and the adipose replacement. So when we look at the pathophysiology, the histopathology, in the first 3 weeks of the animal, there was no pancreatitis, no morphological change, normal pancreas occurred. And after 3-5 weeks, acute pancreatitis occurred with inflammatory cells and necrosis. And around the 4th week, early chronic pancreatitis was diagnosed with dilated ducts, fibrosis, surviving alcinous. And after 2 months, at the age of the mice, the late chronic pancreatitis occurred with fatty replacement. He also analyzed the histological acinar loss, and as you see in the normal histology, there was basically no loss of acinar of the alcinous. In acute pancreatitis, there were some. In the recurrent acute pancreatitis was diverse, but in the CP there was basically a significant loss. They also checked the fatty replacement, the same situation, and checked the pancreas weight and the plasma amylase as well. So the clinical aspect is that we need to stop somehow the progression of the acute pancreatitis to chronic pancreatitis. We need to change. We need the deteriorating factors need to be evaluated and changed, namely the hyperlipidemia, the hypertonia, diabetes, and the obesity. The idiopathic etiology need to be evaluated, and also we need to educate patients about stop smoking and alcohol, and also we need to focus on the cholecystectomy. The Hungarian pancreatitis study group has 2 ongoing randomized controlled trial the Reappear and Emily. These two trials are focusing on the two main etiology, the alcohol and the biliary acute pancreatitis. And there is also the effort study, which is about the dietary habits and also a randomized control trial. Thank you for your attention. If you have a question, I'm more than happy to answer them.
Presentation.
Very nice summary. Thank you very much. Actually, I'm going to ask David to comment on this a little bit for two reasons. In my interpretation, it's more of a comment, not a question really to you. In the original model he put up for early chronic pancreatitis was a mechanistic progression model, where the initial susceptibility factors play heavily into this model. Basically, you already diagnose early chronic pancreatitis even at the beginning, and this is where this whole sentinel episode concept comes in. And actually, the sentinel episode became so popular usage that I ended up writing an email to David that what the hell does this even mean? And then he explained it that actually this alerts the physician to the possibility of progression and early chronic pancreatitis. So I want you to really elaborate on this a little bit here. I think this is a perfect opportunity.
So just briefly, what we notice clinically is that patients will go for many years, and as soon as they have one episode of acute pancreatitis, some of them start having recurrent events. It's not like it's spread out equally over the lifetime. So something happens with the first episode of acute pancreatitis that changes the pancreas to make it hypersensitive. And in some patients, especially ones that have provocative etiologies, the pancreas is susceptible to recurrent attacks. And so that's sort of what the model is. And we hypothesize it was probably immune cells that were there that were driving the hypersensitivity, although epigenetic changes couldn't be made. The question then is, what is early chronic pancreatitis? Because the definition of chronic pancreatitis requires irreversible damage. Well, you want to stop it before it's irreversible. We know what the starting point is, and then what is early chronic pancreatitis, because this would be a reversible stage. And basically, it's a probability estimate, depending on what the patient's smoking and drinking habits are, if they have underlying genetic thing, if they have hypertriglyceridemia, those types of things, and the probability of progressing to chronic pancreatitis is high. If it's, if you can't find anything after evaluation after the first episode of acute pancreatitis, or if there's other things that can contribute to fibrosis or pain, then the probability is lower. So early chronic pancreatitis is a high probability state in which there's underlying damage to the pancreas, and then trying to predict whether or not it's going to move forward. I think what you presented, the Hungarian group showed, is that if you have a process that gives you 3 episodes of acute pancreatitis, you have a driver that's there, and the probability of progressing is high. And that's where you want to do an intervention. So then the concern is what is the intervention? If the intervention is total pancreatectomy, then you don't want to make the diagnosis. If the intervention is eat less fat, then yes, you do want to do the intervention. So the idea of a probability of progressing and the intervention you're going to do to prevent that has to be such that the treatment is less damaging than the natural course, but at least gives us a chance to frame all of the variables so that we can begin thinking about and building models like has been shown here with determining how many episodes really shows that you're on that high risk for progression.
The summary didn't really allow me to go much into the details, but the first author of this publication, Peter Hegg, is going to have a presentation, and I think he's gonna highlight the significant factors that needs to be evaluated and needs to be focused on. So basically, of course, the best would be to prevent all acute pancreatitis, not only recurrent, but also if we have a little sensitivity of which biomarkers we should focus on and must be like measured, then that might help in chronic pancreatitis prevention, I believe.
Yeah, I think one of the best place to get achievement in pancreatology is the recurrent field, because you can get the knowledge after the first acute pancreatitis that these are the patients who are under risk, and 20%. And what we actually published paper was actually a correspondence to Marco's work about a totally insufficient workup after the first acute pancreatitis for the etiology factor. It's definitely multi-etiological factors, including genetic risk, including different metabolic parts, including toxic agents like smoking and alcohol. And I think this is the place where we can do the most, and especially patients' education can come, because and comes a lot. Because the other diseases like pancreatic cancer, of course, we must try, but it's still the probability of going forward. If I look at the last 20 years, or also in decreasing the 3% mortality of acute pancreatitis, we cannot achieve as much as then from acute pancreatitis to chronic. If I look at about the research activities in this field, is extremely low.
And take into consideration the multi-morbid patient with a lot of medication, so the drug-induced component.
Absolutely.
Yeah.
I believe that one of the strengths of this publication was that when we checked CP from the AP registry, we saw that it's 3-4 RAP. And from the CP perspective, we got the same like 3-4 RAP. And also when we had animal model, we had the same, the 3-4. So I think this is the strength. Like we had these 3 ways, and it showed the same direction.
Okay, thank you very much, Kata. It was a very nice presentation.